Okay, let's unpack this. Trying to figure out if a critically ill patient has too much fluid, it can feel like you're navigating a maze sometimes.
Oh, absolutely. It's a
We
real
track
true.
every drop in, every drop out, but how do we really know if their system is overloaded?
Mm.
What are the subtle signs we might be missing early on?
And it really is the central question in managing these complex patients, isn't it? We're super diligent about recording fluid balance, but um, understanding the actual impact of that balance on their body,
Hmm.
that's far from simple.
Yeah, which brings us right to today's deep dive. You shared a really interesting study that tackles this, well, head on. It looks into the connection between fluid overload and something called venous congestion in ICU patients.
That's the one.
It's all in this paper. The title's a bit of a mouthful. Relationship between cumulative fluid balance and the degree of venous congestion, according to VeXus score in critically ill patients in a general intensive care unit.
Haha, yeah, quite a title. But the findings inside are genuinely fascinating.
They really are.
This study sheds some important light on why just looking at the overall fluid numbers might not be enough. And it introduces a pretty promising way to use ultrasound to assess that venous congestion directly.
Right, because you were looking for something that went beyond just the basic fluid balance calculations, and this paper really seems to deliver on that.
Exactly. It gets into the nuances.
So our mission today really is to break down the key findings from this research. We want to understand what it tells us about assessing a patient's fluid status, especially using this newer ultrasound scoring system called VeXus.
VeXus, yeah. Let's start there. What actually is VeXus?
Good question.
It stands for Venous Excess Ultrasound Score. Basically, it's a way to use ultrasound right there at the bedside, point of care, to directly visualize how, well, congested the venous system is.
Okay, so instead of just relying purely on the ins and outs, we're actually trying to get a visual, like, is there a backup in the veins?
Precisely. You've got it. VXUS looks at two main things: the capacity of the veins, like how much they can hold, and also whether there are any signs of blood flowing backward, which, isn't normal.
Kind of like checking if the plumbing's getting blocked up somewhere.
That's a great analogy, yeah. It's like checking for pressure buildup in the system.
Okay, that makes sense.
Yeah.
Now, the study mentions VXUS has been used before, particularly for predicting kidney problems after heart surgery. Why is that link important here?
Well, it highlights that this venous congestion isn't just some harmless state of having a bit of extra fluid hanging around.
Right.
It can have real significant effects on how organs function, and the kidneys seem particularly vulnerable. The fact that VXUS showed promise there suggests it might help us understand the wider consequences of fluid imbalance, not just the fluid volume itself.
Okay, so turning back to this specific study, what were the researchers really trying to figure out? What were their main goals?
Their primary objective was to see how three specific things were related. This was in critically ill patients 72 hours after they got to the ICU.
Okay, three things.
First, the cumulative fluid balance, the net difference, fluids in versus fluids out. Second, the VXUS grade, which measures the level of venous congestion based on the ultrasound.
Right.
And third, whether the patients actually had clinical edema, like visible swelling, and how severe it was.
And how did they go about doing this? What was the setup?
So this was an analytical observational cohort study. They looked at data from 123 adult patients admitted to a general ICU over in Colombia.
Okay.
A key thing is that all these patients had a Foley catheter, a urinary catheter, right from the start of their ICU stay. That allowed for pretty accurate tracking of their fluid balance.
Makes sense for the output side.
Exactly. And they excluded certain patients, those already on dialysis, people with cirrhosis or severe liver disease, those with high pressure in their abdomen, or anyone who'd been in another ICU for more than 3 days before coming to theirs.
So they focused on a pretty specific group, relatively new ICU admissions, without those major confounding factors.
Yeah.
And what exactly did they measure and track?
Well, they calculated that cumulative fluid balance daily.
Mhm.
Importantly, they based it on recorded inputs and outputs, excluding insensible losses, fluid loss through breathing, sweating, that kind of thing.
Which can be hard to quantify anyway.
Very hard, yeah. Then, right at the 72-hour mark, they did two things. Performed the VXUS ultrasound assessment and also graded any clinical edema the patients had. They used the Godet scale for that.
Oh, the Godet scale. That's the one where you press on the skin, right?
Yeah.
See if it leaves an indent.
That's it. You check how deep the depression is and how long it takes to disappear. It gives you a grade, a measure of the swelling.
Right, the classic finger poke test. And the VXUS score itself, How does that grading work? What do the different levels 0 to 3 actually mean?
So the score ranges from 0, meaning no significant congestion, up to 3, indicating severe congestion. It's based on what the ultrasound shows in 4 key veins.
4 veins.
Yep. The big one, the inferior vena cava, or IVC. Then the hepatic veins in the liver, the portal vein, also liver-related, and finally the renal veins in the kidneys.
Okay.
They look at the size of the IVC, and then using Doppler ultrasound, which shows blood flow, they examine the patterns of flow in those other veins. Certain abnormal patterns combined with IVC size push the grade higher. Grade 2 or 3 is generally considered significant congestion.
Got it. So they gathered all this data, fluid balance, VeXus scores, edema grades. What were the big takeaways? What did they actually find about how common venous congestion was?
This is where it gets really quite interesting. They found that some level of venous congestion, defined as a VXUS grade of 1 or more, was seen in over a third of the patients, 36.5%.
Wow, more than a third.
And even more striking, significant venous congestion, a VXUS grade of 2 or higher, was present in 22% of them, nearly a quarter.
22%.
And get this. This was despite the fact that the average cumulative fluid balance across all the patients at 72 hours was only slightly positive. It was around plus 0.88 liters.
Hold on. So almost a quarter of these patients had significant venous backup, according to the ultrasound, even though on average they weren't massively fluid overloaded based on the simple in-minus-out numbers.
Exactly. That's a crucial finding.
That is surprising and really important for you, the listener, because it suggests that even without those big positive fluid balance numbers we often focus on, there could be significant circulatory issues, this venous congestion, already happening.
It really drives home the point that the overall fluid balance number, while useful, might not be giving us the complete picture of what's happening hemodynamically inside the patient.
Okay, so let's dig a bit deeper then into that specific connection. Fluid balance versus the VXUS score. Did they find a clear relationship?
They did find a relationship, yes. Statistically, their analysis showed that for every liter of positive cumulative fluid balance, the odds of having that significant congestion VXUS grade 2 or higher increased by about 31%.
Okay, so more fluid does increase the risk.
It does. The odds ratio was 1.31. And they also saw that patients who did have higher VXUS grades, especially grade 2 or 3, had significantly higher cumulative fluid balances at all times, points they checked 24, 48, and 72 hours. So there's definitely a link. Fluid accumulation does contribute.
But as you pointed out, it's clearly not a perfect one-to-one thing.
Right.
Because many patients had congestion without huge fluid gain.
Precisely. It's not deterministic. It strongly suggests that while fluid overload is certainly a factor, probably an early one, other things must be playing a role too in whether or not someone develops significant venous congestion.
Which brings us to the clinical edema. The good old swelling we look for. How did that correlate with the VXUS findings?
Ah, yes. This is where it gets really, really interesting and maybe challenges some assumptions.
Okay.
They found only a weak correlation between the edema grade on that GODAT scale and the VXUS grade. The Spearman row was just 0.27. Very weak. And clinically, having edema wasn't significantly associated with having significant venous congestion. The odds ratio had a very wide confidence interval that crossed 1, meaning it wasn't statistically significant.
Wow.
And maybe even more telling, almost 60%, 59.3% to be exact, of the patients showed no clinical edema at all, grade 0, at the 72-hour mark.
So wait, someone could have a significant backup in their veins, showing up as a high VXUS score on the ultrasound, but have absolutely no obvious swelling when you check their legs or sacrum.
That's exactly what the data suggests.
It's a huge takeaway. Edema and venous congestion really seem to be potentially quite distinct phenomena. You can apparently have one without the other, at least in this critical care setting.
It appears so.
This really challenges that traditional bedside assessment, doesn't it? Where we equate swelling directly with fluid overload or congestion. Makes you think, how many patients might have this sort of hidden venous congestion that we're just not picking up because we're only looking for edema?
It certainly raises that question. And the study went a bit further, looking for other factors, besides just the fluid balance number, that seemed to be associated with having that significant venous congestion, the VXUS-HU2.
Okay, like what else seemed to matter?
Well, they found a few things. Being male seemed to increase the odds quite a bit, almost 5 times higher risk.
Interesting.
Having pulmonary hypertension, that's high blood pressure in the lung arteries, was linked to an almost 7 times higher chance. That's a pretty strong association.
Yeah, that makes some sense physiologically, pressure backing up.
It does. They also noted associations with a lower left ventricular ejection fraction, meaning the heart's main pumping chamber wasn't working as well. Also, a higher baseline creatinine level, hinting maybe at some pre-existing kidney vulnerability.
Okay.
And somewhat surprisingly, perhaps, the use of loop diuretics, medications like furosemide, often given to remove fluid, was also associated with higher odds of significant congestion.
Huh. The loop diuretic finding is a bit unexpected, isn't it? You'd think they'd be associated with less congestion.
You would think so initially.
So what's the thinking there? Why would that be?
Well, it could be a couple of things. It might be what we call confounding by indication, meaning the diuretics were being given because the patients already had significant fluid issues or congestion, so the drug use is just marking the sicker patients.
Okay. The chicken or the egg problem.
Exactly. Or perhaps in some cases, their effectiveness was limited due to other issues, like poor kidney function or heart dysfunction. So even with diuretics, the congestion persisted or worsened. It really highlights how complex managing fluid is, influenced by so many individual factors.
Absolutely. Now, you mentioned they also compared their findings to other research. What did those comparisons show?
Yeah, they looked at a few other studies, Beaubien et al., Andre et al., Viana et al. These involve slightly different groups. Post-cardiac surgery patients, other general ICU populations, patients after heart attacks.
More findings.
What's really striking is that these other studies also reported pretty high rates of venous congestion, VeXus grades of 1 or higher, often despite relatively low average cumulative fluid balances in their groups, too.
So this isn't just a one-off finding from this Colombian ICU.
Doesn't seem like it. It reinforces the idea that venous congestion is actually a pretty frequent issue in various types of critically ill patients, maybe more common than we realize based on traditional signs alone.
And do those other studies also point to factors beyond just the fluid balance number?
Yes, they did. Similar to this study, that other research also seemed to implicate factors like cardiac function, how well the heart is pumping, as being really important in the development of venous congestion.
Right. So it's not just the volume of fluid, it's the whole circulatory system's ability to handle it, especially the heart's role.
Exactly. It's about the interplay between the fluid load and the capacity of the cardiovascular system.
Okay, so let's try and bring this all together now. What are the main implications? What should we take away from this study for how we think about and assess fluid status in the ICU?
I think there are a few really key implications. First, it does reinforce that fluid overload, that positive balance, is likely an early contributor to developing significant venous congestion. So fluid stewardship still matters a lot.
Okay, good.
However, it also makes it really clear that the cumulative fluid balance number by itself is not a definitive or reliable indicator of how much venous congestion a patient actually has.
Right, not the whole story.
Not the whole story. Second, and this is maybe the big one, it strongly suggests that clinical edema, that swelling we look for, is actually a pretty poor marker for underlying venous congestion, at least at this 72-hour time point.
Yeah, that disconnect was really stark.
It was. We might be missing significant congestion if we only rely on seeing edema. The absence of swelling doesn't mean the venous system is fine.
Critical point.
Third, the study really highlights the importance of considering other factors beyond just fluids in and out. Things like cardiac function, the presence of pulmonary hypertension. These need to be part of our assessment when we're thinking about a patient's risk for venous congestion.
Makes sense. Look at the bigger picture.
Exactly. And finally, it really underscores the potential value of using a tool like VeXus. It offers a more direct sort of physiological window into what's actually happening with venous pressure and flow right there at the bedside.
Of course, like any study, it probably had some limitations, right? Did they mention those?
They did, yeah. They were upfront about it. It's an observational study, so it shows associations, but it can't definitively prove cause and effect. That's important.
Always is with observational data.
Right. Also, their fluid balance calculation was the standard algebraic sum, inputs minus outputs. It didn't precisely measure insensible losses, which, as we said, are tricky but do exist, so there could be some slight inaccuracies there. And lastly, like with any ultrasound technique, there's always the potential for some variability depending on who's doing the scan and interpreting it, though VeXus protocols aim to standardize that.
Understood. Okay, so just to wrap up the main takeaway here for you, the listener. While keeping meticulous track of fluid balance is definitely still crucial, this research really hammers home that venous congestion in critically ill folks is complex.
It really is.
It's not always perfectly mirrored by those simple fluid balance numbers, and crucially, it's often not reflected by whether a patient looks swollen or not. This VXUS score seems to offer a potentially valuable, more direct way to see what's actually going on inside the venous system.
That sums it up nicely, and maybe it leaves us with a final thought for you to chew on.
Go for it.
Given these findings, how might our whole understanding of fluid overload and how we manage it in critical care need to evolve? Should we be thinking about moving beyond just focusing intensely on the input-output numbers and maybe incorporating these more direct physiological assessments like VXUS earlier and more routinely?
That's a really provocative question. Definitely something to mull over. And if you, listening, are interested in digging deeper into point-of-care ultrasound and the VXUS score specifically, we'd certainly encourage you to explore that area further. It really does seem like it could be a valuable piece of the puzzle in tackling this ongoing challenge of managing fluids in our sickest patients.